speaker is Dr. Kennedy Miller. Everybody knows it. It's a pleasure to introduce him, Medical Director of International Endoscopy Service, California Pacific Center. He will be speaking on advances in EUS guide procedures.
And we'll have questions at the end, so don't feel like you don't have a shot at EUS persists.
Thank you, Wally, and thank you, John. And sorry to have to break away from the live, because the live is really the exciting part. But actually, there are a number of recent advances in EUS-guided procedures that I'd like to touch on and highlight. And in the 15 minutes that I have been allocated, I'm going to touch on these following 6 advances. So let's start with pancreatic duct access and drainage. As you can see, we can access the pancreatic duct anterogradely from the stomach, so transgastric, or from the duodenal bulb, transduodenal. And we're accessing the duct anterogradely in contrast to the retrograde access that we perform with ERCP, and therefore I like the term EAP to contrast it from ERP, EUS-guided anterograde pancreatography. The indications for EAP are either a failed ERP, that is to say you tried to cannulate retrogradely and it failed, or in situations where you simply cannot reach the papilla, and obviously that's mostly in the context of post-surgical anatomy, patients with a Whipple or a post-bypass procedure, or B2. So we've accessed the pancreatic duct anterogradely, we've injected our dye, we have our pancreatogram, and our drainage will occur with either 1 or 2 strategies, depending on whether we can pass our wire across the obstruction into the bowel. And if we can pass that wire into the bowel, then we can perform a rendezvous retrograde drainage. That is to say, we're going to exchange our echoendoscope for a duodenoscope, and then we're going to proceed with our ERCP in the standard fashion. But if we cannot pass that wire across the obstruction into the bowel, then we have to resort to a direct anterograde drainage. And so we're going to place a stent, for example, to drain the pancreatic duct directly into the stomach. And I call this EAPD, EUS-guided anterograde pancreatic drainage. And the other approach, the rendezvous approach, would be the RV-ERP. So RV-EAP, there's a number of publications on it, totaling 75 patients. The treatment success is very high once you can get that wire into the bowel, because then it basically becomes an ERCP. And there are some complications, but those complications are mainly related to pancreatitis that we're familiar with from ERCP. Now the challenge is getting that wire across the obstruction into the bowel, and therefore the technical success is only 72%. So what if the wire does not pass the obstruction into the bowel? And so this is the difficult part. This is the challenge. It's EAPD. Firstly, we have to dilate that tract in order to instrument the tract, and there's often fibrosis and calcifications in patients with chronic pancreatitis. We often require cautery to create that tract using, for example, a needle knife or a cystotome. And in turn, this can result in an increased risk of pancreatitis, bleeding, and leakage. Also remember that the pancreas is not adherent to the stomach wall, even though it may appear so. There is the lesser sac between the stomach and the pancreas. It's a mobile target, and it easily displaces. There is a risk of leakage into the lesser sac with complications of infection, pancreatitis, and peritonitis. And here you could see at the time of surgery where we placed a stent from the pancreatic duct into the stomach, you can see that gap in the lesser sac. That's that space between the organ and the stomach. Now I've compiled the literature for you here in this table, and I've extracted out the patients who underwent EAPD. And what you can see is that the overall technical success rates are fairly good, pain relief is good, but we have a number of severe complications, and I've looked at just the severe complications, and we're looking at a rate of 11% with several perforations and leakage. So this is clearly not a benign procedure, and I think we need better tools to improve the safety of EAPD. Now let's switch over to the drainage of fluid collections. You're all familiar now with drainage of pseudocysts, which are pure fluid collections. I think we have a fairly standardized procedure today where we access the duct with a 19-gauge needle, pass our wire, dilate the tract, and then place multiple stents. And you can see our success rates are very high and our complication rates very small for pseudocysts. Now, walled-off necroses is a different animal. Here we're dealing with an encapsulated form of pancreatic necrosis with liquid-solid contents. And historically, this has been off limits to us because of the difficulty draining the solid debris, the necroses. It was Hans Seifert, a former colleague of mine in Hamburg, who first described the NOTES approach to necrosectomy. 3 cases, all with failed EUS guided stenting, used a large caliber balloon to create a fenestration, if you will, to the cavity. Then he performed necrosectomy with various extraction tools, baskets, and snares, and performed weekly necrosectomy until resolution in all these patients. And if we compile the literature published to date, we can see 246 patients. The median number of sessions is 3, but sometimes up to 12 sessions are required of necrosectomy. Our resolution rates are actually quite good at about 80%, but our complication rate is staggering. This is 29% complication rate. So this is obviously also not a benign procedure. Now, the use of a self-expandable metal stent to facilitate the drainage of these collections was first reported by Michel Cahaly when he was at the University of Virginia. And, sorry, let me just go back here. And you can see that in these 18 patients here, he had fairly good cyst resolution rates, but also here the complication rate of 44%, including an inner migration of a self-expandable metal stent. That's obviously not an easy complication to deal with. It was a German group that then reported the use of a self-expandable metal stent, a larger diameter of 20 to 25 millimeters, that used this as a port to perform necrosectomy through the SEMS. This group removed the necroses after 2 to 3 procedures and had no migrations. And you can see here the stent inside too, and they're passing the endoscope through the SEMS, so using the SEMS as a port to perform necrosectomy. And I think this is an interesting novel concept. And in fact, really what we need then for this is a Lumen-apposing stent with 2 large flanges, obviously much shorter, to just straddle the walls of the cyst and the bowel. And these 2 large flanges, which are double-walled, are lumen-opposing. And I had the honor of collaborating with Dr. Itoy in this first publication on using this stent to drain fluid collections, high technical success rates, and then using it as a port for pseudocystoscopy and necrosectomy. And here you can see some images of what this would look like inside of the walled-off necroses. And then we're extracting the necroses through the stent. Here's how it looks after necrosectomy. We can even retroflex and look back on ourselves. You can see that distal flange hugging up against the wall of the cyst. And this is a video quickly showing a recent case that I did after placing a 15 millimeter lumen-opposing stent. And we're able to grab, using the Roth net basket, we're able to grab some of these necroses and pull this out. Obviously, this is a very tedious procedure, requires multiple intubations of the cyst, and that's why the stent is so helpful. And I also like to use the EMR cap to suck the necroses up into the cap and then extract the necroses. And this is a video showing the use of the hot axials. It's not available yet in the United States, but it's used in Europe where it's approved, as well as using this to place a nasocystic catheter. And I feel that irrigation is a very key part of the procedure. You can see the deployment of the distal flange after we enter with cautery into the cyst and immediately deploy the distal flange. Then the proximal flange is deployed under endoscopic guidance. You can see that here. Immediately the fluid component drains out, and then we can immediately enter through that stent using it as a port to gain access to the cavity and performing irrigation. Here you can see a large amount of necrosis. And rather than spend our time performing necrosectomy now, we'll flush it with hydrogen peroxide, which is very effective at debridement, and then we'll immediately place a nasocystic catheter, and then we will aggressively flush out these contents over several days with saline and hydrogen peroxide. And to emphasize the importance of irrigation, I'll call your attention to this randomized trial. It's the Dutch trial that compared endoscopic transgastric necrosectomy with surgical necrosectomy. And this study showed, although the numbers are not large, only 20 patients that got randomized to the two groups, they used pigtail stents and nasocystic irrigation in all of the patients. So this was a cornerstone of the therapy, and this study showed in its endpoints that there was a significant reduction in the complications and the number of pancreatic fistulas. So let's switch to celiac neurolysis. What's new here? It's no longer a debate of whether we should use a central or bilateral approach of our injection. A few years back from Indiana, a very nice study from LeBlanc showed us in this randomized trial that the two are really equivalent, so it's up to the operator's choice. And using the plexus neurolysis technique, we inject a large volume to create this cloud around the plexus. What more of us are doing now is a select ganglia approach, where we are targeting the individual ganglia. These are small ganglia that we can now visualize with the better resolution on EUS. And here you can see a video showing the targeting of these ganglia, which look like little sesame seeds or almonds. They often have an echogenic center, sometimes with some filamentous strands. Those are the rami that are coming off of the ganglia. And then we'll inject 1 or 2 cc's of the sclerosant into the ganglia only. And so we're limiting the collateral damage of the procedure with this more selective approach. This is an important trial that was published last year, a randomized trial that compared EUS-guided celiac ganglia neurolysis versus the celiac plexus neurolysis, showing, the multi-center trial, by the way, showing that CGN was superior. However, the ganglia were not visualized in about 12% of patients. So if you cannot see the ganglia, then you have to resort to celiac plexus neurolysis. Tumor ablation, as you know, there are a number of different modalities that we can use: injection, radiofrequency, HIFU, PDT, brachytherapy, all fascinating technologies. The bottom line for you today is that all of these remain experimental. There's really no proven survival advantage, and I think that's understandable considering that with pancreatic cancer we're dealing with systemic disease. And when you deal with local disease, such as a neuroendocrine tumor, these can be really well treated today laparoscopically with wedge resections or even enucleation. What about cystoablation? Well, this is an area where I think that we will play a growing role. We have evolved from ethanol ablation, where we had poor efficacy and pancreatitis. We've now evolved to ethanol and paclitaxel, much better efficacy, but the complication rates remain high, and even in some of the resected cases, there was residual abnormal epithelium. And I think the direction that we're going now is to just use chemotherapy and eliminate the alcohol. This is the CHARM trial from the University of Pittsburgh that we are awaiting, which is a randomized trial of chemotherapy alone versus chemotherapy and ethanol. For right now, I think we want to follow Dr. Castillo's recommendation that we should keep the alcohol and the chemotherapy locked in the cupboard, and let's await those further trial results. And finally, let me just touch on fiducials. These are studies showing that smaller is really better. We can use this very thin fiducial 10 millimeter gold coil that can be passed through a 22 gauge needle. So that makes the placement of these fiducials, especially when we're down the duodenum, much more easy. And Cook will be soon coming out with this fiducial needle where 4 of these seeds can be preloaded into a 22 gauge needle. So let me conclude by saying that rendezvous EAP is very appealing, but the problem is that you may not be able to pass your wire across the obstruction into the bowel, in which case you have to resort to EAPD, and that remains challenging and risky. For cyst drainage, the lumen-apposing SEMS, I think, is a very exciting new addition to our armamentarium, especially for ward-off necroses. For celiac neurolysis, let's target the ganglia, try that first when visible, and if not, then we'll resort to plexus neurolysis. For tumor ablation, we can do it, but what is the benefit? So should we be doing it? Cyst ablation, let's go alcohol-free, and we await those trials. And finally, fiducial markers, smaller is better.